The nutrition care process is a standardized structure and framework used to provide nutrition care. The 4 steps are assess, diagnose, intervene, monitor, and evaluate. Each step requires critical thinking skills. Critical thinking integrates facts, informed opinions, active listening, and observations. It is a reasoning process where ideas are produced and evaluated. It includes the ability to conceptualize, think rationally, think creatively, be inquiring, and think autonomously. Nutritional screening is the use of preliminary assessment techniques to identify those who are malnourished or at risk for malnutrition. All members of the healthcare team can participate in screening. It should be quick, easy to administer, and cost-effective. Screenings and referrals bring people into the nutrition care process. A screening tool may provide some evidence of an emerging nutrition problem. If none exists, document that discharge from nutrition care is appropriate. Note, cultural competence is the ability to provide care to patients with diverse values, beliefs, and behaviors, and tailor delivery to meet their social, cultural, and linguistic needs. Prioritize nutrition risk. The Joint Commission requires that a nutrition risk be identified in hospitalized patients, but does not mandate a method to accomplish screening. Rescreening should occur at regular intervals during hospitalization. There may be a link between length of stay and worsening nutritional status. Examples of nutrition screening tools are listed. Please note the acronyms and the features of each. The subjective global assessment includes information from the patient on dietary intake history, weight changes, GI symptoms, and primary diagnosis. The mini nutritional assessment, the Nutrition Screening Initiative, and the Geriatric Nutritional Risk Index focus on older adults. The Malnutrition Screening Tool looks at recent weight loss and recent poor dietary intake in the acute hospitalized adult population. Nutrition risk screening includes percent weight loss, body mass index, and dietary intake in medical, surgical, hospitalized patients. The Malnutrition Universal Screening Tool includes BMI, unintentional weight loss, and the effect of acute disease on intake for more than 5 days. Nutrition assessment is the first step of the nutrition care process. Its purpose is to obtain adequate information in order to identify nutrition-related problems. It is initiated by referral and/or screening of individuals or groups for nutritional risk factors. 3 components of the nutrition assessment are review, cluster, and identify. Review the data collected for factors that affect nutritional and health status. Assessment data is clustered for comparison with characteristics of a suspected diagnosis. Data is organized into categories: food nutrition-related history, anthropometrics, medical tests, nutrition-focused physical findings, and client history. These indicators are compared to identified standards and criteria for interpretation and decision-making. Indicators are clearly defined markers that can be observed and measured. Indicators may also be used to monitor and evaluate progress towards nutrition outcomes. A nutrition indicator is what will be measured. Nutrition care criteria are what the indicators are compared against. Quality documentation should include date and time, pertinent data collected and compared with standards, and the reason for discharge or discontinuation if appropriate. Assessing nutritional status includes gathering information on the patient's dietary habits. When conducting a diet history, try not to ask leading questions, those that lead the client to the answer you are seeking, showing your bias. The food record is kept by the patient. The 24-hour recall produces the best information when the dietitian is involved, clarifying the exact types and amounts of foods consumed. Thus, it is best conducted in the clinical setting with your help. Note, under- and over-reporting are concerns. The Food Frequency Questionnaire is a quick way of obtaining intake information from large groups, such as in community nutrition projects, and can be done without your help. The medical or health history includes family history of disease, present and past health issues, surgeries, and psychosocial data. This provides insight into nutrition-related problems. Physical findings are also included in the assessment. Anthropometrics measure body structure and include height and weight. Note the formula used to calculate desirable body weight, including the information on amputations and spinal cord injury. Note the percent weight change formula stresses the significance of the change in weight and is used to assess potential nutrition risk. The tricep skin fold measures body fat and estimates calorie reserves. The arm muscle area is a good indication of skeletal muscle or somatic protein. Measuring the AMA is important in growing children. It is useful in identifying possible protein-energy malnutrition. The body mass index compares weight to height. Note the healthy BMI for adults. Waist circumference is an independent risk factor for disease when out of proportion to total body fat. Note the waist-to-hip ratio is indicative of increased risk for obesity-related diseases like diabetes or hypertension. Bioelectrical impedance analysis is used at the bedside to evaluate fat-free mass and total body water. The patient must be well hydrated, restricting caffeine, alcohol, diuretics, and exercise prior to the test. The BOD pod measures body composition, determining body density by measuring the amount of air displaced. The nutrition-focused physical exam includes inspection, palpation, auscultation, and percussion. Inspection is a visual assessment using sight, sense of smell, and hearing to observe textures, sizes, colors, shapes, and sounds. Information is obtained on obesity, cachexia, fluid status, skin integrity, wound healing, feeding devices, jaundice, and ascites. Thin, dull, dry, brittle hair may be due to a deficiency of vitamin C. Easily pluckable hair may be due to a protein deficiency. Palpation gathers data via touch using palms and fingertips. Look for areas of tenderness, muscle rigidity, fluid retention or pitting edema, skin integrity and moisture, and body temperature. Auscultation is listening to the bowel using a stethoscope on the right lower quadrant, which is the location of the ileocecal valve. Normal bowel sounds are gurgling, high-pitched sounds every 5 to 15 seconds. Hypoactive bowel sounds every 15 to 20 seconds may indicate paralytic ileus or peritonitis. Hyperactive, continuous, high-pitched tinkling sounds may indicate diarrhea or intestinal obstruction. Percussion, looking for obstruction or ascites, is not done by the RDN, but findings are recorded in the medical record. Intake and output measurements are used to assess hydration status and measure fluid balance. Serum albumin is a visceral protein. It maintains colloidal osmotic pressure. When levels of albumin decrease, water in the plasma moves to interstitial spaces, causing edema. Note, a serum albumin above the normal range is usually due to dehydration. Because of its long half-life, it does not reflect current protein intake. Serum transferrin transports iron to the bone marrow for production of hemoglobin. The iron storage pool controls the plasma transferrin level. When iron stores are depleted, transferrin synthesis increases. This is used in diagnosing anemia. Transthyretin is a visceral protein that turns around in 2 to 3 days, so picks up changes in protein status more quickly. Retinol-binding protein circulates with prealbumin. It binds and transports retinol. Hematocrit and hemoglobin together evaluate iron status. Serum ferritin indicates the size of the body's iron storage pool. Creatinine is released from muscle cells and excreted by the kidney with little reabsorption. Serum creatinine measures somatic protein and, together with the BUN, assess kidney function. Note the normal range. The creatinine height index is a ratio of the creatinine excreted compared to height. Note the normal BUN and the normal BUN to creatinine ratio. BUN is related to protein status and renal function. Urinary creatinine clearance measures the glomerular filtration rate. Note the normal TLC, which measures immunocompetency. It is decreased in protein-calorie malnutrition. C-reactive protein is a marker of acute inflammatory stress. As it declines, it is used to indicate when nutritional therapy would be most beneficial. Free erythrocyte protoporphyrin is increased in lead poisoning. Lead depletes iron, leading to anemia. Lead competes with calcium for transport. Note the normal prothrombin time. Anticoagulants prolong the prothrombin time. A change in vitamin K intake will alter the clotting rate. Analysis of human hair is not useful in nutrition assessment. It may be used to measure the intake of toxic metals. Energy requirements based on activity levels are listed. Note the activity factors. Some of the effects that drugs have on nutrient absorption and use are listed. Note the following. Megestrol acetate and marinol are appetite stimulants. Adderall suppresses appetite. Ritalin may cause nausea and anorexia. Avoid grapefruit juice when taking statin drugs. Oral contraceptives may decrease folate levels. Loop diuretics deplete thiamine, potassium, magnesium, calcium, and sodium. The thiazide drugs decrease potassium and magnesium but enhance the renal absorption of calcium. Methotrexate, a chemotherapeutic agent, decreases folate. Lithium and sodium are reabsorbed at the same sites in the kidney. Low sodium intake leads to retention of lithium at toxic levels. Patients should maintain a consistent sodium and caffeine intake to stabilize the drug. 2-gram sodium diets may be too low. Anticoagulants antagonize vitamin K. Avoid high doses of vitamins A and E and the botanicals that interfere with blood clotting. Propofol is administered in oil, providing 1.1 calories per cc. The immunosuppressant cyclosporine, leads to hyperlipidemia, hyperglycemia, hyperkalemia, and hypertension. Isoniazid, which treats tuberculosis, depletes pyridoxine, leading to peripheral neuropathy. Take the drug away from food. It interferes with vitamin D, so calcium supplements are needed. Elevil may lead to weight gain. Vitamin B6 and protein decrease the effectiveness of levodopa. Take the drug in the morning with fewer than 10 grams of protein. Consume most protein with the evening meal. Tyramine can cause hypertension if consumed with MAO inhibitors. Aged or fermented foods should be avoided. Advise the patient to buy, cook, and eat fresh foods. Turmeric may reduce inflammation. Socioeconomic factors to consider include those that influence food choices, such as income, the price of food, the time available to shop and prepare food, and proximity to food sources. What are their sources of nutrition and food information? What media do they watch or use? As you assess your client's nutritional status and needs, consider their readiness or willingness to make dietary changes. The main focus of nutrition education is to develop permanent behavioral changes. Note, how to teach depends upon the needs and the readiness of the learner. A general wellness assessment is a process that involves being aware of better health and actively working towards that goal. When assessing the nutritional status and needs of a community, obtain an overview to determine whether nutritional resources are adequate, what groups are potentially at high nutritional risk, and how well health needs are being met by existing programs. Then identify the target population and nutritional problem of concern. Note the HRA, Health Risk Appraisal, is a survey that categorizes a population's general health status. Include demographics, morbidity, and mortality rates. Note the infant mortality rate expresses the number of deaths per 1,000 live births. Note the difference between incidence and prevalence. Incidence refers to the number of new cases of a disease that develop within a time period. This is a measure of the risk of developing the disease. Prevalence is the number of existing cases of a disease in a community at that point in time. Also assess local health resources to identify the services offered and evaluate them. What are the cultural features of the community? What school nutrition and social welfare programs are available? What is the educational attainment and native language of the community? Food security is having access by all people at all times to sufficient food. The Community Food Security Initiative is the development of sustainable, community-based strategies to ensure that all have access to culturally acceptable, nutritionally adequate food at all times. These strategies focus on local food systems like farmers markets, food recovery programs. Note, PPFP, Prepared and Perishable Food Programs, link foods with agencies that serve the hungry. Food insecurity is prevalent among emergency food recipients. It affects all ages, ethnicities, and locations. It impacts the working poor. It extends to government food assistance recipients and those with poor health status. Note the difference between the nutrition survey and surveillance. A survey examines a group at a particular point in time and is a cross-sectional study. It provides information on the prevalence of a condition at a specific time. nutritional surveillance is the continuous collection of data. It is used to identify nutrition problems, set priorities, and it detects changes in trends over time. Note, the system is based on height, weight, hematocrit, hemoglobin, and cholesterol levels. Surveillance is an ongoing system linked to an active health program like WIC and the CDC. The data used should be produced by these health programs. This data identifies needs and the kind of intervention that is needed. The Nutrition Screening Initiative focuses on the elderly and tries to identify their nutritional problems early. The NSI uses the Determine checklist to highlight the warning signs of poor nutritional status. The Level 1 screen identifies those who should be referred for a more comprehensive assessment. The Level 2 screen is used when the others identify more potentially serious medical or nutritional problems. Note, RDNs are most involved with Level 2. A focus group is brought together to talk about their concerns, beliefs, and problems. This provides attitudinal information. The National Nutrition Monitoring and Related Research Program includes all data collection and analysis activities of the federal government related to measuring health and nutritional status, food consumption, and attitudes about diet and health. The Pediatric Nutrition Surveillance System follows low-income, high-risk children, monitoring growth and nutritional status. The Pregnancy Nutrition Surveillance System follows low-income, high-risk pregnant women. It counts the number of women who breastfeed. A goal is to identify and reduce pregnancy-related health risks. Note, what we eat in America is the dietary intake component of Hanes. The USDA conducts nationwide surveys of food consumption. The Behavioral Risk Factor Surveillance System conducts telephone interviews with adults looking for certain behaviors. The Youth Risk Behavior Survey collects data on priority health risk behaviors of those in grades 9 to 12. Note, both the behavioral and youth risk factor surveillance systems can monitor changes in health risk behaviors over time and can better target health promotion efforts to populations most at risk. The FDA's Food Safety and Nutrition Survey is conducted to assess consumers' awareness, knowledge, understanding, and reported behaviors related to food safety and nutrition-related topics. The goal is to make better informed regulatory, policy, and education decisions to promote and protect public health. Referral procedures are essential for the continuity of care and to maximize services available from other sources. The following are nutrition assistance programs currently offered by the government. Note who runs the program, who is eligible, and what services are provided. Under the Temporary Assistance for Needy Families program, states determine eligibility and the benefits and services they will receive. The USDA's Food Distribution Program provides foods to help meet the nutritional needs of children and adults. The Commodity Supplemental Food Program is run by state health agencies. Note, it provides monthly foods to low-income elderly at least 60 years of age. The National School Lunch Program, note, is an entitlement. Entitlements are assistance programs that require the payment of benefits to all eligible people as established by law. Note, the lunch menu must provide 1/3 of the recommendations for the items listed. Note, the school breakfast program is also an entitlement program, providing 1/4 of the recommendations for those same items. after-school snack programs provide healthy snacks. The Special Milk Program provides milk to children in schools which do not participate in other federal meal service programs. Note the Summer Food Program is an entitlement program and aids food service programs for children when school is not in session. Note the Child and Adult Care Food Program provides healthy meals and snacks to child and adult day care facilities and homeless shelters. It provides food and education. The Fresh Fruit and Vegetable Program helps develop eating habits that improve health and prevent obesity. WIC is administered by the USDA and provides food, education, and referrals to other agencies. A health care exam is required. WIC is not an entitlement program. Benefits are obtained through the EBT card. FNEP is designed specifically for nutrition education. It does not provide food. It works with small groups, teaching how to budget, shop, and cook. The Maternal and Child Health Program is a federal program concerned with the health of mothers, infants, and children. The Healthy Start Program funds programs in communities with high infant mortality rates. The Older Americans Act Nutrition Program is for all age 60 and older plus their spouse, regardless of income. Congregate meal services are for the ambulatory. Home-delivered meals are for the homebound. SNAP is the largest food assistance program and it is an entitlement. It provides monthly benefits through the EBT card. Head Start introduces new foods and teaches good food habits. The child's participation in food activities is an important part of the plan. The Nutrition Education and Training Program trains teachers and school food service personnel. The Senior Farmers Market Nutrition Program provides low-income seniors with coupons to be exchanged at farmers markets, roadside stands. Eligible foods include fresh, nutritious, unprepared fruits and vegetables. In addition to these government-sponsored programs, there are also quasi-governmental agencies that provide nutrition assistance, like the Red Cross and the National Research Council. Note, Feeding America, a non-governmental agency, is the largest domestic hunger relief organization in the United States. The FAO is the international agency most directly connected with food. Nutrition diagnosis is the second step of the nutrition care process. It identifies a nutrition problem, a risk of a problem, or the potential for developing a nutrition problem that dietetic professionals are responsible for treating independently. The nutrition diagnosis changes as the patient's response changes. The medical diagnosis is a disease or pathology that can be treated or prevented. It does not change as long as the condition exists. Pathophysiology is the disruption of normal body functions that is seen in disease. Differential diagnosing determines which of many problems with similar symptoms is the correct diagnosis. This requires comparisons and contrasts of all findings. The diagnosis links assessment to intervention and sets realistic and measurable outcomes. The Academy's standardized language is the basis for collecting evidence that nutrition care improves outcome. Nutrition diagnoses are organized in 3 categories. The clinical domain represents nutritional findings or problems that relate to the patient's medical or physical condition. It includes functional balance issues like swallowing, or chewing difficulty, or altered GI function. Biochemical balance is a change in capacity to metabolize nutrients due to medications, surgery, or indicated by lab values. Weight balance refers to chronic or changed weight status when compared with usual body weight. The intake domain describes actual problems related to intake of calories, fluids, and nutrients. The behavioral environmental domain refers to problems related to knowledge, access to food, and food safety. A nutrition diagnosis is best written as a PES statement pertaining to one problem, one etiology, and connecting signs and symptoms. The problem, the diagnostic label, is an adjective that describes the human response, such as altered, impaired, increased, risk of. The etiology is the cause or contributing risk factors linked to the problem by the words related to. Assessment of signs and symptoms are linked to the etiology by the words as evidenced by. Select the most important and urgent problem to be addressed. Evaluate the PES statement by asking the following questions. Can you resolve or improve the nutrition diagnosis for this person or group? Note, if you have diagnoses from two domains, consider intake diagnoses as more specific to the nutrition professional. They are more likely to facilitate a nutrition-directed intervention. Is the etiology you selected the root cause that can be addressed with nutrition intervention, or can you at least lessen the signs and symptoms? Will measuring the signs and symptoms indicate if the problem is resolved or improved? Are the signs and symptoms specific enough that you can monitor and document resolution or improvement of the nutrition diagnosis? Overall, the question to ask is, does the nutrition assessment data support a particular nutrition diagnosis with a typical etiology and signs and symptoms? Identifying the etiology leads to the selection of a nutrition intervention aimed at resolving the underlying cause of the nutrition problem when possible. If that is not possible, then the nutrition intervention is targeted at minimizing the symptoms of the problem. If the assessment indicates that no nutrition problem currently exists that warrants a nutrition intervention, use the words "no nutrition diagnosis" at this time. The critical thinking skills needed include finding patterns and relationships among the data and possible causes, making inferences. If this continues, then this is likely to happen. Stating the problem clearly and being objective. Rule in or out specific diagnoses, and prioritize the relative importance of problems. Nutrition planning and intervention is the third step in the nutrition care process. It is based on the nutrition diagnosis and provides the basis upon which outcomes are measured and evaluated. Sources for intervention methods include evidence-based dietetics practice. Our recommendations are based on scientific evidence. What does the best evidence tell us about the most effective intervention methods? Community-based intervention programs are divided into three categories. Primary prevention programs try to reduce exposure to a promoter of disease, such as early screening for risk factors like diabetes. This is health promotion. Secondary prevention programs recruit those with elevated risk factors into treatment programs. This is risk reduction. Tertiary prevention programs intervene as the disease progresses to reduce severity and manage complications. Organizations fighting against healthcare fraud and food fads include the FTC and the National Council Against Health Fraud. Documentation in medical records is determined by the facility. We all follow the HIPAA guidelines, which provide direction as to properly entering a note in a medical record. When diet orders are not chosen correctly, contact the person who wrote the order to make the change. Note, you can change your own entry, but not one made by another person. Discharge planning begins on day 1 of a hospital stay. All patient information is confidential. Intervention includes medical nutrition therapy. The first group of conditions we will review are the gastrointestinal disorders, beginning with the ulcer, which is an eroded mucosal lesion. Note the cause of many ulcers is the H. pylori bacteria. Treatment includes antacids, antibiotics, rest, and diet therapy. Note the diet is as tolerated, whatever does not aggravate the patient's condition. Avoid late-night snacks. There are, however, some items known as gastric irritants, which should be omitted from their intake. A hiatal hernia is a protrusion of a portion of the stomach above the diaphragm into the chest. Heartburn is the main symptom. Note the feedings should be small, and patients should avoid late-night snacks. The dumping syndrome occurs after a gastrectomy. After the patient recovers from surgery and begins to eat food in greater volume and variety, he may experience a cramped, full feeling, rapid pulse, perspiration, and dizziness. These post-gastrectomy symptoms are associated with the dumping syndrome. When a meal containing a high proportion of readily hydrolyzed carbohydrate rapidly enters the jejunum, water is drawn from the blood into the intestines to achieve osmotic balance. This causes a rapid decrease in the vascular fluid compartment, so blood pressure drops and signs of cardiac insufficiency appear. About 2 hours later, this concentrated solution of carbohydrate is rapidly digested and absorbed, causing a rise in blood sugar. This stimulates an overproduction of insulin that leads to a drop in blood sugar below fasting. Note, this is reactive or alimentary hypoglycemia. Billroth 1 attaches what is left of the stomach to the duodenum. Billroth 2 connects it further down to the jejunum, so this is a more serious surgical procedure. When food bypasses the duodenum, the secretion of secretin and pancreozymin will be reduced. These are the hormones that stimulate the pancreas, so now there is little pancreatic secretion, leading to steatorrhea. Note calcium and iron absorption are adversely affected. A B12 deficiency develops from a lack of intrinsic factor and bacterial overgrowth in the loop of intestine being bypassed. Pernicious anemia is diagnosed using the Schilling test, note which is looking for the intrinsic factor. A folate deficiency follows as it needs B12 for transport inside the cell. Contributing factors include poor folate intake and low serum iron. Careful control of the diet can alleviate the symptoms. Feedings should be small and dry, with fluids before or after meals to slow passage. Restrict hypertonic concentrated sweets. Provide 50 to 60% complex carbohydrate, protein at each meal, and moderate fat. B12 injections may be needed. Note, following a complete gastrectomy, deficiencies of iron, B12, folate, calcium, D, B1, and copper may develop. Gastroparesis is associated with surgery, diabetes, viral infections, and obstructions. Moderate to severe hyperglycemia may slow gastric emptying with long-term detrimental effects on gastric nerves and motility. Prokinetics, like erythromycin and metoclopramide, increase contractility of the stomach and shorten gastric emptying time. Provide smaller, more frequent meals. Shifting the diet to more pureed or liquefied foods is often helpful. Avoid high-fiber foods and fiber supplements. Fat in liquid form is well tolerated. Avoid caffeine, mint, alcohol, and carbonation. Tropical sprue, caused by a bacteria, virus, or parasite, is a chronic recurrent GI disease characterized by intestinal lesions. Note the symptoms include deficiencies of folate and vitamin B12. Treatment includes antibiotics and a diet high in calories and protein, with intramuscular B12 and oral folate supplements. Non-tropical sprue or celiac disease is a reaction to gliadin. This affects the intestinal tract, causing malabsorption and macrocytic anemia. Note, a gliadin-free, gluten-restricted diet is imposed. Note all of the items to be avoided. Corn and cornstarch, potato and potato starch, and rice are permitted items. Constipation is treated with a high-fluid, high-fiber diet with exercise. In diverticulosis, small mucosal sacs protrude through the esophageal or intestinal wall. Note the diet is high in fiber. When these sacs become inflamed, diverticulitis occurs. Provide a clear, liquid diet, gradually returning to the high-fiber plan. Fiber provides indigestible bulk that promotes intestinal function. Note, oat bran and soluble fibers decrease serum cholesterol by binding bile acids, causing more cholesterol to be converted into bile, which lowers the serum cholesterol level. Note sources of soluble fibers. Gastritis, an inflammation of the stomach, is treated initially with clear liquids advancing as tolerated. Inflammatory bowel disease has two classifications. Crohn's disease primarily affects the terminal ileum, leading to a B12 deficiency. There is diarrhea and loss of weight. Chronic ulcerative colitis is a disease of the colon. Note, chronic bloody diarrhea and loss of electrolytes are major symptoms. Treatment for IBD begins with maintaining fluid and electrolyte balance and may include the use of an anti-diarrheal agent. Nutritional management includes energy needs according to current BMI. Limit fat only if steatorrhea is present, for a high fat intake may improve energy balance. If steatorrhea is present, assess the need for calcium, magnesium, and zinc, which are lost in a fatty stool. Provide protein at each meal and chewable water and fat-soluble vitamins. Coconut oil-derived MCT is an easy-to-oxidize source of energy and may improve bowel damage. The nutritional goals in treating irritable bowel syndrome are to provide adequate intake, tailoring the pattern to their specific GI issues. The client should track their intake and associated symptoms. Assist them in alleviating the stress associated with eating. Avoid gas-forming foods and swallowing air during eating. The FODMAP diet may be used to guide the patient through the process of eliminating foods that may contribute to distension and gas production. Lactose intolerance is due to a lactase deficiency. Lactase splits lactose into glucose and galactose, which are easily absorbed into the bloodstream. If lactase is missing, the lactose molecules remain intact and exerts hyperosmolar pressure, causing water to be drawn into the intestines to dilute the load. This causes distension, cramping, and diarrhea. bacteria then ferment the undigested lactose, releasing gas. This condition is detected with the breath hydrogen test or the lactose tolerance test. If you are intolerant after consuming lactose, the blood glucose level will rise less than 25 milligrams above fasting, presenting a flat curve. If you are tolerant of lactose, the rise would be above 25, a normal glucose curve. Note the diet eliminates animal milk. Whey has lactose. Some do tolerate yogurt and small amounts of aged cheese. Acute diarrhea in infants and children is aggressively treated with immediate rehydration by replacing the fluids and electrolytes lost in the stool. Chronic, nonspecific infantile diarrhea is not associated with significant malabsorption. Look at the ratio between the nutrients provided and the volume of ingested liquids. Some are inadvertently given a diet that has too little fat, too many calories, or too many fluids. To control the condition, adjust the fat intake, balanced with limited fluids. Note, restrict or dilute fruit juices with a high osmolar load. No fruit juice before the age of 1. Children up to age 6 should be limited to 4 ounces of fruit juice per day. Besides bowel rest, the nutritional care for the adult with diarrhea includes replacing fluids and electrolytes lost in the stool. Prebiotics and probiotics may help. Prebiotic components, which promote the growth of healthy bacteria, include fructooligosaccharides, found in onion, garlic, and banana. Probiotics are sources of bacteria used to reestablish bacterial gut flora and include fermented dairy foods and fermented foods with beneficial live cultures. Steatorrhea is a consequence of malabsorption. Note a stool fat greater than 7 is indicative of malabsorption. The short bowel syndrome results from significant resections of the small intestine. The severity of the condition depends upon the length and location of the resection and the health of the remaining tract. Particular concerns include the loss of the distal ileum, the ileocecal valve, and the colon. Most digestion takes place early in the intestine, in the duodenum and upper jejunum. If the jejunum has been resected, the ileum over time can take over its functions. It is when the ileum is resected that the patient experiences significant challenges. Note the distal ileum is where bile salts, the intrinsic factor, and vitamin B12 are absorbed. The ileum also absorbs most of the fluid passing through the tract. Patients should drink at least 1 liter more than their ostomy output daily. If bile salts are not reabsorbed, the liver is not able to produce enough new ones to adequately emulsify lipids. Fats and fat-soluble vitamins are malabsorbed. The malabsorbed fats then combine with calcium, magnesium, and zinc, interfering with their absorption. The colonic absorption of oxalate increases, leading to renal oxalate stones. When the colon is resected, the concerns include the loss of water, electrolytes, and salvageable carbohydrates and other nutrients. Initial care may include parenteral support. However, enteral feeding should be started early and increase gradually over time as adaptation allows. Following a jejunal resection, provide a normal balance of nutrients. Note, but following an ileal resection, fat intake is limited. Without the ileum, bile salts are not recycled, so are not available to emulsify fat. Provide some fat as medium-chain triglycerides, which do not require bile salts. They also require less intestinal surface area for absorption. Note, supplement the fat-soluble vitamins, calcium, magnesium, and zinc. Parenteral B12, followed by monthly B12 injections, may be needed if more than 100 centimeters of the terminal ileum has been removed. The liver controls a major portion of the body's internal environment. When the liver is diseased and its usual activities do not proceed normally, many metabolic functions are disrupted. A healthy liver stores and releases blood, filters toxins, metabolizes nutrients, and regulates fluid balance. All of these are affected during liver disease. The enzyme profile is a list of the major enzymes found in the liver. When tissue damage causes them to leak out into the circulation, the enzyme level in the blood rises. Note, elevated enzyme levels indicate tissue damage. Under the heading Liver Function Tests are 3 liver enzymes evaluated. Note the top of each range: ALP-120, AST-35, ALT-36. In liver disease, they are all elevated. Hepatitis is an infectious disease characterized by inflammation and partial necrosis of the liver. Necrosis is the death of a tissue due to lack of oxygen. Note, anorexia is a major symptom. HAV, hepatitis A, is the type most directly connected to food. Provide a high fluid intake to guard against dehydration. Nutrition care varies according to their symptoms and nutrition status. Include 50 to 55% of energy as carbohydrate to help replenish liver glycogen stores. Provide 1 to 1.2 grams of protein per kilo. The high protein intake not only helps the liver regenerate its cells, but it also provides lipotropic agents to convert fat into lipoproteins to move them out of the liver. This high protein intake helps prevent a fatty liver. Provide moderate to liberal fat intake if tolerated. Limiting fat may be needed with steatorrhea. The difficulty in providing this much nutrition support is that hepatitis patients are often anorexic, so small, frequent feedings are advised. If fluid retention occurs, restrict sodium. Liver disease may advance to the chronic state of cirrhosis. Here, the liver attempts to regenerate its damaged cells by replacing them with bands of connective tissue. This tissue is non-functional and divides the liver into small, irregular clumps, disrupting the flow of blood through the liver. Increasingly poor food intake leads to a number of nutritional deficiencies. Protein deficiencies may contribute to ascites, a fatty liver, or impaired blood clotting. When the liver is healthy, blood from the esophageal, abdominal, and collateral veins enters the portal vein, which takes it to the liver to be cleansed. Blood is then redistributed back through the body by way of the vena cava. Note, ascites occurs when blood cannot leave the liver. The problem is the connective tissue overgrowth. As it blocks blood flow out of the liver into the vena cava, the blood backs up inside the liver. The liver, acting like a sponge, can store about 1 liter of excess blood. But once that storage capacity has been exceeded, there is no place for the blood to go. It can't leave the liver, and it can't stay inside the liver. So fluid from the blood seeps through the liver into the peritoneal cavity. This fluid is almost pure plasma with a high osmolar load. That pulls in additional fluids from surrounding tissues. This accumulation of fluid and the sodium that it carries is ascites. This fluid circulates through the vascular system, diluting lab values. Another complication of cirrhosis is the development of esophageal varices, which develop when blood cannot enter the liver. The connective tissue overgrowth prevents blood from entering through the portal vein. The blood then backs up into the vein, causing, note, portal hypertension. This increased pressure forces the blood back up into the abdominal and esophageal veins. Increased blood pressure in these small, fragile vessels forces an outpouching of the vessel wall known as a varice. These varices are very fragile. They can burst open on their own or can be torn open with a diet high in roughage. The nutritional therapy for cirrhosis includes an adequate to high protein, high calorie, moderate to low fat intake. Fat is the preferred fuel in cirrhosis. Include omega-3 fatty acids, and decrease long-chain triglycerides if steatorrhea develops. Restrict fiber if varices are present, and restrict sodium as needed. Alcoholic liver disease has 3 stages: steatosis, hepatitis, and cirrhosis. It is due to the constant presence of alcohol itself and the metabolic changes that result. Alcohol is converted to acetaldehyde, releasing large quantities of hydrogen. The hydrogen steps into the TCA cycle in place of fat. So the fat accumulates, either in the liver, leading to a fatty liver, or in the blood, raising the triglyceride level. Malnutrition usually accompanies the disorder. The major nutritional concerns are listed. Note, supplement thiamine and folic acid. A long-term thiamine deficiency may contribute to the Wernicke-Korsakoff syndrome. The need for magnesium increases. It is excreted after alcohol consumption. Hepatic failure or end-stage liver disease occurs when the function of the liver decreases to 25% or less of normal. Here, the liver can no longer convert ammonia into urea, so it builds up in the blood, leading to confusion, drowsiness, and coma. Asterisk is a sign of impending hepatic coma. For the patient who is not comatose, provide moderate to high levels of protein. To minimize muscle catabolism, provide extra energy from carbohydrates and fats. Low sodium if ascites is present. Non-alcoholic fatty liver disease can be managed with lifestyle changes, including slow weight loss, healthful eating, including the Mediterranean diet, and physical activity. Cholecystitis is an inflammation of the gallbladder that usually results from a low-grade infection. Treatment includes a low-fat diet. Note, following a cholecystectomy, bile is directly secreted from the liver into the intestines. Limit fat intake for several months to allow the liver to compensate. Slowly increase fiber to help normalize bowel movements.